Thank you all for joining. And as I'm Quinn, I am a professor in the Department of OBGYN at New York University. And we thank you for joining the Oncofertility Consortium webinar today. The webinar will take about 45 minutes, followed by 15 minutes for questions. Please keep your mic muted and your camera turned off throughout the webinar to reduce the noise and create a smooth broadcast. If you have a question, please post it in the chat. We'll open the discussion at the end of the webinar where you can turn on your mic and camera if you want to ask a question directly, or you can put your questions in the chat and I will read them to the speaker. The webinar will be recorded and uploaded to the Oncofertility Consortium. Missing the bottom part of that, Oncofertility Consortium YouTube channel. So it is now my great pleasure to introduce Dr. Marleah Kruzel, who is a wonderful colleague and friend. She's an associate professor in the Department of Communication at the University of South Florida, and she's a collaborative member of the Health Outcomes and Behavior Program at Moffitt Cancer Center, and chair of the Health Decision-Making Special Interest Group of the Society of Behavioral Medicine. So welcome, Dr. Kruzel, and I'll turn it over to you.
Thanks so much, Gwen. I appreciate that introduction. Good afternoon from Tampa, Florida. It is sunny and beautiful as per the usual. So I really appreciate the invitation to come and talk with you about reproductive or fertility health decisions as a previvor. My research spans across the cancer continuum with a special emphasis on health decision-making and communication of genetic risk information. But today, specifically, I'd like to share with you 3 research projects that are focused on previvors' health and fertility decision-making. Before I begin, I just wanted to note that I don't have any disclosures and acknowledge that funding for 2 of the projects was from the American Cancer Society. And I would also like to acknowledge that this work couldn't be done without an excellent research team and colleagues, one of whom, of course, you'll recognize Dr. Gwendolyn Quinn. So thank you again, Gwen, so much. So when I was 8 years old, my mother here found a lump, and it was a tiny lump. It was barely even noticeable. But I watched her undergo breast surgery, chemotherapy, radiation, and then later a prophylactic mastectomy on the other side and reconstruction. She was diagnosed with breast cancer. My childhood experiences living in hospitals and attending as many appointments as my parents would allow me really sparked my early interest in health communication, the use of communication strategies to understand and improve patients and their family members and clinicians' health experiences and outcomes. In fact, it's probably the main reason for why I decided to become a researcher. Was way back then as an 8-year-old, I wanted to give back to the medical community who I thought had saved my mom's life. And then when I was 25, during my doctoral work, I decided to undergo genetic testing myself because I wanted to know if I was genetically predisposed, like my mother, like her 2 sisters, and my great-grandmother and my grandfather, I was genetically predisposed to get cancer as well. Now, after I tested positive for BRCA2, I began surveillance, rotating between breast MRIs and mammograms every 6 months. And I quickly realized I was overwhelmed. I was overwhelmed with my uncertain future and what it would bring. Uncertainty exists when we believe that aspects of our situation are ambiguous, complex, or unpredictable. And although I was experiencing uncertainty, like a good researcher, I wanted to know if others were experiencing the same thing. And I thought, this is great. I'll conduct research with patients who've tested positive for BRCA, who have not been diagnosed with cancer like myself, so that perhaps I can help them. And in the process, I'll help myself. That was 10 years ago. Since my dissertation, my personal and professional journey has sought to understand and improve health experiences and decisions of those with inherited cancer risk. Genetic testing for cancer predisposition helps identify individuals at significantly increased risk to develop cancer, and it helps guide prevention and treatment to reduce cancer incidence and mortality. Now, those with inherited mutations who have not been diagnosed with cancer, like myself, are often referred to as unaffected carriers, but they're more commonly known as Previvors. This label was coined by the national nonprofit organization FORCE, which is an organization dedicated to helping those affected by hereditary cancer. As you will likely know, the most recognized Previvor is Angelina Jolie. And research conducted by myself and others has found that Jolie's health announcements raise the public's awareness about genetic testing, prophylactic surgeries, as well as empowered many patients to consider their own possible hereditary cancer risks. The term Previvor was motivated by the need to not dismiss the significant ongoing stress and complex decision-making that these individuals go through, thereby recognizing them as survivors of a predisposition to cancer. In other words, what Previvors face is a level of certainty that their risk for developing cancer is very high, but they also live with this chronic uncertainty about that risk, not knowing if they will develop a cancer, and if they do, when they will develop cancer, as the quote shows you here in this slide. But as genetic testing becomes more widely accessible and available, the Previvor population, their health needs, and their decisions will continue to likely grow. Now, extant research supports the notion that risk-related uncertainty is inherent for Previvors. It's more intense. It is experienced chronically. And as I mentioned earlier, uncertainty exists when we believe aspects of our health situation are ambiguous, they're too complex, or they're unpredictable. So for example, some of my research has identified two main sources of uncertainty for Previvors and how they must manage these sources. One is medical uncertainty and the other is familial uncertainty. Medical uncertainty includes being anxious about a future cancer diagnosis due to an inherited cancer risk, feeling fearful during those increased surveillance appointments, as I shared earlier, and or waiting for diagnostic test results when hereditary cancer is suspected. Familial uncertainty includes distress when reflecting on families' cancer memories, such as a death in the family, or worrying about how hereditary cancer diagnosis could affect current or future children. Now, the problem is that when uncertainty exists and it's left unmanaged, then we start to see these detrimental effects among this population. There's poor decision-making and also even potentially increased cancer diagnoses and mortality. In fact, there's a few studies that have found that Previvors may face more psychological distress than even patients who are diagnosed with breast cancer. Thus, Previvors' ability to cope with distressing information is essential. Now, for Previvors, managing their uncertainty means making medical decisions. And Previvors really have three main options, other than doing nothing, for managing their inherited cancer risk. The first is increased surveillance, right? Actively monitoring the body for the development of cancer. Number two, prophylactic surgeries, removing breast tissue to prevent breast cancer, and or perhaps both, removing the ovaries and the fallopian tubes to prevent ovarian cancer. And then there's chemo prevention, administering medication to delay cancer as well as reduce the risk of cancer. And so this leads me to the first of three studies that I would like to share with you today. In our first study, it was framed by uncertainty management theoretical constructs, and we identified two decision-making pathways for Previvors, which manifested differently depending on their decision. And what I mean by decision is their uncertainty management choice. And that was really based on their perceived threat and the available information that they had. So let me tell you a little bit about the sample. This was a qualitative study in Nature. I primarily conduct qualitative research, and I conducted telephone interviews with 46 female BRCA1 and 2 Previvors. And following IRB approval, I recruited participants through force as well as then snowball sampling. And my colleague and I, Dr. Fisher, we conducted thematic analysis using the constant comparison method. Now, it is important to note that in this sample, while chemo prevention, as I mentioned, is one of those options for managing risk, it did not occur as an uncertainty management decision or way of process in this particular sample. So let me tell you about the first pathway. The first pathway was risk-reducing surgery. Most participants chose surgeries. And as depicted in this pathway here, previvors who assessed or appraised their uncertainty as a danger chose surgery as their risk-reducing medical decision, which then reduced their uncertainty and ultimately resulted in health-enhancing outcomes. Appraising their uncertainty as a danger meant that they saw it as a gamble or a risk and thus experienced heightened or extreme distress. For example, one previvor in this study said, "I don't even gamble in Vegas. Why on earth would I gamble with this?" Two factors informed previvors' risk-reducing surgery decision: being done with having children and then feeling like a ticking time bomb. Another previvor explained, "I just felt like, why am I going to wait to get cancer? I valued my life more than my body parts." Finally, previvors who choose surgery reported interconnected health-enhancing outcomes, which highlight the complexity of chronic risk-related uncertainty. In other words, previvors described how their decision to undergo surgery ultimately eliminated their disease probability and enhanced their psychological well-being. One previvor said, "I don't have to worry about getting cancer every day." The second pathway that we identified was increased surveillance. So these previvors appraised their uncertainty as an opportunity instead of a danger, like the previous pathway. So they chose increased surveillance as that risk-reducing decision, and that ultimately resulted in both health-enhancing but also health-inhibiting outcomes. And these previvors noted that two characteristics really informed that appraisal of danger as appraisal as opportunity, not danger. First, they described an opportunity for personal control. So one previvor said, "Having a plan to do something about it definitely gives me some control back." Second, these previvors stressed the importance of having the ability to detect cancer early, which many of their other family members who had been diagnosed with cancer did not have a chance to do. Two factors informed previvors' increased surveillance decision: wanting to have children and concerns about surgical side effects. For example, a previvor emphasized, "My main thing is that I want to have a family." And last, previvors who chose surveillance reported both those health-enhancing and health-inhibiting outcomes, and that was really tied to their uncertainty. They described how initially when they made their decision, it helped them manage their risk-related uncertainty at first, which promoted health and reduced their uncertainty and distress. However, their uncertainty then persisted because it was managed. It was not reduced, as in the case of those women who chose surgery. And so they continued to experience the psychological distress associated with chronic uncertainty. This is best demonstrated by one previvor who said, "If I do nothing and wait, and then I get sick, I had all this knowledge and I wasted it." So we found this aspect of the results really interesting, that even after making their decision to engage in increased surveillance, these previvors continued to experience this risk-related uncertainty. And so with that in mind, we went back to the data and extended our analysis, and we found that in the case of increased surveillance, previvors were experiencing cyclical uncertainty. This process was cyclical, it was not linear. So in other words, for these previvors, their uncertainty was no longer described as an opportunity, as initially it was, but then became a danger. However, their danger appraisal was different than that first pathway I talked about, where those previvors who selected risk-reducing surgery. For these previvors, their danger appraisal was informed by this experience of distressful uncertainty triggers, which tended to be surveillance appointments and family planning. Now, after reappraising their uncertainty as a danger, Previvors described this idea of reconsidering options over and over. Now, they didn't end up changing their decision to do surveillance because they wanted to have a family, but they did constantly reconsider those options. And so as time went on, they talked about time being past and older age, and the fear of pushing that surgery forward, but still wanting to do it in the future so that they could complete their families. Finally, Previvors' reappraisal and subsequent ongoing contemplation of these options was health inhibiting and was really embedded in that psychological chronic uncertainty that had to be continually managed. One Previvor said, "I'm gambling that I can live my happy life enough for a few more years, or as many more years as I can push it, and I pray to God that I don't get cancer." So overall, the findings from this study illustrate the complex decision-making process of Previvors as depicted in this lifespan model that you see here. And it really highlights two important points. Previvors make sense of decision-making options by assessing the impact of their decision on uncertainty and that chronological psychological distress. And number two, Previvors' lifespan factors, which you see located in the middle of the epicenter of this model here. And it demonstrates that these decisions, as well as participants' uncertainty and related psychological distress, are influenced by lifespan factors. So becoming an adult, finding a partner, perhaps getting married, and ultimately building one's family. Which then brings me to the next part of my presentation, where I will discuss Previvors' fertility decision-making. So as I just noted, one lifespan factor that's important to this aspect of Previvors' health journey is building one's family. And to be clear, for the purpose of this presentation, I define family building as the act and process of decision-making about children. So this could be timing, the type of method, the approach, and even the number of children. Yet Previvors have unique challenges and concerns when they're making family planning decisions. As just one example, couples may be concerned about their inherited cancer risk for future offspring, as carriers have up to a 50% risk to pass on their pathogenic variant to each future offspring. Now, there's little research, but some has found in the case of inherited cancer risk and making fertility decisions, this is really difficult and tends to take time for Previvors. And this is because, as I alluded to in the first study, that Previvors have to manage that cancer risk management decisions as well as building their families. And so that has implications for the loss of childbearing or breastfeeding, for example. Now, some of my research has found when making family building decisions that Previvors enact logical decision-making and emotional decision-making styles. So in other words, they consider undergoing these risk-reducing surgeries in a logical time frame that's recommended by their healthcare providers, clinicians, and national cancer care guidelines. But they also keep in mind their emotional desires to be mothers and often have biological children and breastfeed. So to this end, some research has found that Previvors consider postponing and ultimately do postpone those risk-reducing surgeries in order to complete their families. A final challenge relates directly to the fertility process. So we have found that research racial and cultural differences for those utilizing assisted reproductive technology. As you likely know, one option for Previvors is to utilize in vitro fertilization to select embryos without an inherited gene mutation. However, recent research has found that disparities exist, with non-Hispanic white women as more likely to utilize assisted reproductive technologies in comparison to non-Hispanic Black, non-Hispanic American Indian and Alaskan Native, Native Hawaiian or other Pacific Islander, and Hispanic women. Yet what complicates this decision-making further is that it's not individual, right? It's interpersonal. That means that it involves communication between multiple interactants or partners. And when communicating about family building, Previvors and their romantic partners specifically often experience communication challenges. So for one, discussing these beliefs about passing on a pathogenic variant to possible offspring can create a lot of tension and conflict, but not just between the patient and the partner, but also even the extended family as well. There's some research that I did a few years ago with Previvor specifically, and I asked them to tell me some advice for newly diagnosed Previvors when having these difficult conversations with partners. And here are the strategies. Engage in a two-way dialogue with their partners across the lifespan. So when you start dating, perhaps when you get serious, and as you continue to make these decisions. Seeking information about assisted reproductive technologies early, specifically PGD, and doing that together, but also doing some research separately, and then coming together and discussing. Recognizing each other's social support needs, and then acknowledging and managing those emotions when making these difficult decisions. So that leads me to the second study I'd like to share with you, which is specifically about couples with inherited cancer risk. So this was a longitudinal study that was made up of 15 couples or 30 individuals. And following IRB approval, couples were recruited through social media and Stonewall sampling. And couples gave informed consent and then participated in semi-structured discussion tasks, followed by a dyadic interview with both the patient and the partner across 2 different time points. And both patients and partners received compensation. My co-authors and I then utilized the constant comparison method to code the data, and we did that in a qualitative data analysis program called MaxQDA. And we also performed member checks to ensure that the results resonated with participants. So let me kind of walk you through this process. To begin, when couples start to exchange information about family building options, or as you'll see, I've put an acronym, FBOs, we identified the following concerns: family building options, the risks, family building options, considerations, and then genetic related logistics and life logistics. The first concern related to couples' discussions about risks, which tended to surface when they were weighing different options for building families: adoption, surrogacy, IVF, no intervention, etc. And this concern really involved 2 main dimensions. They talked about inherited cancer risk to their children and then getting cancer while they were pregnant. So for example, one Previvor stated, "My number one concern would be passing on that gene mutation to a child and then increasing their risk of cancer over a lifetime." The second concern encompassed discussions of factors which obstruct, delay, or otherwise inhibit decision-making. And this concern included 4 dimensions. And I don't have time to talk about them all now, but I'll just give you an overview. One was misunderstanding the risks and the benefits to each of those options, the costs and finances associated with the different family building options, the role of emotions, and the ethical and moral beliefs and values about having children. So for example, one partner shared, "I think I want to look more into that and understand the pros and cons of IVF and the risks associated with it." The third concern involved discussions of factors related to inherited cancer risk along 2 dimensions. So these are the genetic related logistics. Time pressure was one dimension, and risk management and cancer death. For instance, one Previvor shared, "Timeline issues are a concern. The longer that we spend trying to figure out the best way to do this, or waiting for the best technology to be available." And then the last concern was life logistics. And this was completely unrelated to inherited cancer risk. This concern included 5 dimensions, and those were personal and relational impacts, age, career, and housing, and then COVID-19. For example, one Previvor shared, "I know that you," referring to her partner, "want to wait as long as we can to get pregnant, but I'm concerned if we wait too long, I won't be able to get pregnant easily." All right, so moving on. So they've exchanged information about family building options, and now they start deliberating. Now they start trying to figure out, okay, talking about it more in detail. And when they started deliberating about their family building decisions, they talked about that there were some easy conversational topics, and then there were also some difficult conflict-inducing conversational topics. So on the one hand, easy, couples shared that family building options and potential children's cancer risks due to a genetic variant were actually pretty easy to discuss. One partner, for example, said, "For me, what is pretty easy is discussing the what of what's going on, the various options." In contrast, couples disagreed about the future timing of various family building options and specifically prophylactic surgeries. So for instance, one Previvor shared, "I think we did have a little bit of conflict about the timelines. Are we going to keep gathering information forever? Are we just going to start trying to have a family? At what point do we stop planning?" Last, when relaying their final decisions, couples reported selecting both a plan A and a plan B for completing their families. And as you can see here, an equal number of couples reported those primary or plan A family building options, choosing to have children without any intervention at all, and then via in vitro fertilization. And then one couple had already chosen adoption. Additionally, 7 couples were undecided during this study about their second plan B, though they had discussed having a plan B. And 2 couples, while 2 couples each had chosen to have children without intervention via IVF, via fostering, and then also having no children. So in short, the results of this second study demonstrate really a shared decision-making process that couples go through when they're communicating about family building and inherited cancer risk. And you can see those concerns from the information exchange phase listed here. And then in that second, you see the overview of the deliberation phase and that process of really starting to think about the pros and cons of decision making. And then ultimately this idea of, while we might have a primary decision ultimately that we come to after having these difficult conversations, they also have a plan B, so that if their first choice is unsuccessful, then they have a contingency plan. So overall, this work is helpful, I think, because it demonstrates not only what couples talk about when they're trying to make these family building decisions, but it also underscores the importance of considering how time, because previvors have time, right? They haven't been diagnosed with cancer, how time really shapes their decision making. And also, I'd like to point out that the study results demonstrate that when making these decisions, it's not just about passing on the genetic variant, right? That some of them were concerned about their relationship, how their career might be impacted, and things like that. Another contribution is the focus on partners. Now, there's some research on Previvors communication, as I mentioned earlier, but there's really less. It's less clear about partners' family building experiences and decision-making preferences. So taken together, these first 2 studies demonstrate a need to develop and utilize psychosocial conversational resources or tools to help facilitate this difficult decision-making process, which leads me to my last study I'd like to share with you. So given this need, we developed the caring tool, Communication About Reproduction and Inherited Genes. It's a theoretically informed tool. It's multi-stage, it's a dyadic decision-making tool really designed for dyads, which really we're trying to provide ongoing support to these dyads in order to complement the evolving role of genetic counselors in this genomic era. So the last study I'd like to share with you describes the feasibility, acceptability, and the impact of the caring tool. So we conducted a single-arm pilot with structured discussion tasks about family building concerns and decisions over 2 time points. At both time points, couples first completed a structured discussion task and then an online post-discussion questionnaire, followed then by a dyadic interview. We recorded and transcribed both the discussion tasks and the dyadic interview data, and we used the analysis of applied thematic analysis. So I'd like to share with you a little bit about the tool before I report the results. So the tool starts by setting up the context, and we explain that many couples in their situation struggle with decision making when trying to build their families in light of their inherited cancer risk. They might have concerns such as passing on their inherited mutation to future children. The focus of time point 1 is to really help the couple identify and discuss those initial concerns about family building. And in the comfort of their own home at a time that's convenient for them, the couple begins by listing 3 concerns on a sheet of paper or their phone that they have about building their family, knowing their inherited cancer risk. And then they rate these concerns from most important to least important. Next, the couple takes turns sharing these concerns with each other. And to help facilitate this conversation, the tool provides a few questions such as, why did you choose to share these concerns with your partner? What are your thoughts and feelings surrounding the concerns that your partner just shared? And what might be some things that you can do to address the concerns that were shared? This first conversational experience or exercise is completed in about 15 minutes. A few months later, at time point 2, the couple has another structured conversation. And once again, we set up the context saying that it's been a couple months since your last conversation. And research has found when talking about family building options and inherited cancer risk, that couples oftentimes report difficulty when having these conversations because topics tend to come up over and over again. So thus the focus of time point 2 is to get them to discuss and understand each other's concerns. This is known as communicated perspective taking in my field, with the goal of making a family building decision. So first, the couple lifts one topic that's related to family building and inherited cancer risk that is easy to discuss with your partner, difficult to discuss with your partner, and then one that creates disagreement or conflict. Next, the couple is instructed to share those topics with each other. And then again, we provide some guidelines for facilitating this conversation. This conversational experience or exercise takes a little bit longer, 15 to 20 minutes. So overall, we found the carrying tool is a feasible and acceptable intervention. Feasibility was assessed in 2 ways: recruitment success and intervention completion. Now, although our initial recruitment through clinic referral was not successful, the target sample was recruited within 2 months after moving to online and snowball sampling recruitment methods. And this was likely due to COVID-19 because we were conducting during the peak. 15 couples participated in this longitudinal study at time 1, and then 13 couples participated in time 2. We had 2 couples withdrew that had to withdraw because of a change of fertility status made them ineligible to complete the study. For time 1's discussion task, participants rank ordered their concerns, and only 1 participant listed 2 concerns instead of 3. For time 2 discussions task, couples listed a topic that was easy to discuss, difficult to discuss, and caused conflict or disagreement. And a few couples in this point said that it was a little difficult for them to come up with concerns that actually caused conflict or disagreement. Accessibility was assessed in 2 ways as well. So we did that through dyadic interviews after they've completed the discussion tasks to determine if the participants liked the intervention and if they found it helpful. And then also those post questionnaires to determine their perceptions of the interaction with their partner and their emotional responses, which you'll see listed in the table here. Couples noted overall the usefulness of the pilot intervention. Although most participants had said that they had previously talked about their concerns about building their families, they really appreciated the organized nature of the discussion task because these conversations usually happen haphazardly at the dinner table or driving in the car or something like that. So for example, one Previvor said, having the time for structured conversations is really cool. It's different. Usually these things come up haphazardly. So when you really have time to talk about it, you end up being more focused, which is nice. Additionally, as seen in this table, post questionnaire results at both time points revealed that the intervention was not stressful and that participants felt relatively high levels of intimacy and disclosure. In terms of the pilot intervention's outcomes, we identified 3 main themes from those dyadic interviews, which you see listed at the far left column. And you see exemplar quotes, which I don't have time to read through, but you can kind of get a sense of them on the far right. So first, Previvors and their partners, they noted that the discussion task really helped them realize concordant concerns. So in contrast to organic conversations that just occur in everyday life, in the dyadic interviews, couples stated that the discussion tasks really helped them discuss each other's perspectives about the different family building options that they could use, and how and why certain options were prioritized or vital to them accomplishing their family goals. Second, couples noted that the task prompted them to discover and or confront discordant concerns. Discovering discordant concerns sometimes resulted in highlighting relational conflict. However, discovering this discordant concerns was not always negative. So for example, some couples actually shared that learning their partner's discordant concerns allowed them to take note of that, to understand their partner's unique perspectives, and ultimately help them work together to identify new options that they could consider together. And then finally, couples noted that the task helped them work through and agree upon those next steps to have children. So in other words, the discussion tasks focus on discussing those concerns about family building and inherited cancer risk, allowed couples to really take stock of similar and dissimilar concerns, and then jointly identify those next steps for family building. In summary, to our knowledge, the Caring Tool is the first developed tool for couples with inherited cancer risk, focused specifically on those who haven't been diagnosed with cancer. And results indicate that this pilot intervention is feasible and acceptable, and it provides a starting framework for guiding communication about family building decisions. It's novel because it included the perspectives of partners as instrumental stakeholders in fertility health decision-making. And it also, by providing that structured time and facilitating communication between couples, we believe that the Caring Tool really helps partners and previvors reach that agreement about completing their family while still considering the previvor's inherited cancer risk. So in short, the Caring Tool, we hope, may aid fertility and genetic clinicians in clinical interactions with couples interested in family building and those interested also in assisted reproductive technology specifically. Finally, I wanted to point out that because of our sampling strategies in these studies, this likely attributed to the lack of diversity in the samples. So it's our goal in the future to explore couples' experiences who are genetically, racially, ethnically, socioeconomically, and sexually diverse, explore their experiences and see if this resonates. Additionally, future studies, we hope, will include larger sample sizes so we can really assess the efficacy of the Caring Tool in terms of assisting couples with, or dyads with, their decision-making, decisional regret, communication satisfaction, and that communicated perspective taking. So as I reflected on how to end this, I remember back to a few years ago when I was an assistant professor, and my father sat me down all seriously, and he said, "Marleah, don't you want to study something less personal?" And while I wish I had tested negative for BRCA, I am a previvor with an uncertain future. But I refuse to be limited by something that may or may not happen. So instead, I choose to embrace this part of my identity, striving to help others while continuing to challenge myself. And I choose to embrace my uncertain future by following my mother's wise words to make the best decisions I can with the information I have at that time. Thanks so much for your time and attention, and I look forward to your questions.
Thank you, Marleah. That was amazing. And I have 6 questions already in the chat, and I'm going to read some of them, but I want to also encourage anybody to ask your question directly. These questions are not in any particular order.
Okay.
Is the caring tool also applicable to men with inherited cancer, or is it predicated upon women with the inherited cancer disposition?
That's a great question. Thank you so much. Yes. No, it can be applicable to men with inherited cancer risks as well. In fact, in our sample, I believe there were at least 2 male previvors. And so these conversations are still relevant to them as well. But in our samples, the majority were female, but same conversations occur. And in fact, maybe a little bit different, obviously, if you're talking about IVF specifically, but we do think that it is applicable there as well.
Okay. The next question is, genetic counselors are supposed to be non-directive. Who administers the caring tool, and what resources are available to help with decision-making?
That's a great question. Yeah, absolutely. And this is something, as you know, Gwen, we've been discussing in terms of next steps for the caring tool. I would love not to turn it back to all of you, but you are the experts in terms of the clinical care. I don't know yet is the answer. What is difficult as a previvor, living with inherited cancer risk myself, and what I have found over the last 10 years working with previvors and their families, is that there really isn't a space for us. There are obviously the National Comprehensive Cancer Network guidelines for the types of decisions we can make, but in terms of a place for psychosocial support and decision making, it's not always clear, and it depends on the person's experiences and their goals and things like that. So we have talked about possibly providing it at genetic counseling appointments. It could be helpful there as kind of like a touch place, like you should be thinking about this, or you could be thinking about this, I should say. But as many of you probably know, that can be an overwhelming time when you get those genetic test results back and you're trying to make, cancer risk management decisions. So that might be a little overwhelming, but a good touch point. Another option is in fertility clinics and centers. But at that point, usually most of the previvors who are coming to see and seek care, they already know about their inherited cancer risk. So maybe they've already kind of, started along the path of, I want to do in vitro fertilization or something like that. Could be OBGYN as another possible option. So I think a next step for us is really going to have to be, where is it best? Where does it fit best? But if anybody has suggestions or recommendations, I would be more than open to that.
Okay, well, while people are thinking, how would you handle the communication if the previvor doesn't have a partner but is still interested in family building?
That's an excellent question. And I'm so glad that someone raised it, because it's something, again, that our research team has been thinking about, particularly because, more and more people are undergoing genetic testing and early too, right? If people are getting genetic testing and learning their inherited cancer risk at, 25 and starting to make, increased surveillance decisions, et cetera, it's relevant for them. And they might not have a partner yet. They might not be ready. So we would like to, in the future, expand this caring tool out outside of the romantic partner dyad, and consider maybe family members who could be a touch point, a helpful person to kind of think through, help the previvor think through what's important to them in terms of building their family. So yes, I think that the caring tool can be used in other dyads, perhaps a mother who underwent, cancer, and talking through these decisions with them, maybe a valued friend. So I think it can be potentially applicable outside of that romantic partner dyad.
Okay, thanks. This person's saying, don't women have to wait until age 35 for prophylactic surgeries? So yeah, just that's how it
Don't they
ends.
have to wait? Yeah. So I think the recommendations for I think I had the slide up. I believe, let me just look at it. Yeah, National Comprehensive Cancer Network guidelines is, that risk reducing mastectomy to remove all breast tissue. And I think it depends on BRCA1 versus BRCA2 specifically. So I'll point you to NCCN guidelines for that so that I don't misspeak. But there are specific recommendations. And there's also for risk reducing salpingo oophorectomy to remove, ovaries and fallopian tubes. I think it states that it's commonly between age 35 and 40 or upon completion of childbearing. So I don't know if that answers the question exactly. So again, going back to the idea that this, if a previvor has, learns their inherited cancer risk at 25, they potentially have 10 years of, this uncertainty cycle that they go through in making these decisions. So I don't know if that's helpful. If you have any, given your expertise, if there's anything else you think we should add, please feel free to do so.
I think that you answered the question, because I think the issue was, and as you alluded to at the end, it's not just age 35, it's when childbearing is complete. So if people can
Right.
make these family building decisions in their late 20s, early 30s,
Yeah.
they may still be eligible for this surgery rather than waiting till they actually turn 35.
Yeah, absolutely. Thank you.
Can you address the costs that are associated with ART for previvors, and do they get any special financial assistance because of their genetic status?
Yes, that is a great question. And as far as I am aware, maybe others on the call are, but as far as I'm aware, there isn't coverage like across the United States. Some states have coverage for IVF. Florida is not one of them. And I did, some of the research when I was interviewing with these women, I would add the costs and finances obviously came up in that second study. And that was a burden. It's already difficult to even do, increased surveillance, depending on, if you have insurance and what kind of insurance plan that you have. So the financial side is definitely a consideration. But as far as I'm aware, also there's no grants or nonprofit organizations that will cover in vitro fertilization, assisted reproductive technologies, PGD for previvors. But that's what I'm aware of.
Okay. I want to give the audience again another chance to unmute and ask a question before I ask my question. So my question is really an ethics one, and it's just for your opinion, and some of it will potentially be addressed in the webinar that we'll be having next month.
Oh, fabulous.
There's currently been controversy about people using PGT to test for something specific, and whether or not the clinic has the right to say, if we test, we don't implant if it's positive, versus patient autonomy to say, I know the status of my embryos and I should be allowed to make my own choice about what I do. So just wondering if you have any thoughts about that.
Yeah, that's a great question. I think that for me, and just, being immersed in Previvors' lived experiences the last 10 years, both, female and male experiences, I think ultimately we as patients, we want to make the decision, we want the autonomy. So while, I think it makes sense if the clinic is, maybe being upfront in advance and saying, these are kind of our policies and you're kind of in their hands and have to make your decision. But ultimately, I think empowering patients as best we can, giving them the psychosocial support and autonomy to make their decisions along with their, support partners. I think that's what's most important. But given where genetic testing is going and the access to it, it's probably going to continue to be a topic that continues to come up. So I don't know, maybe I can jump on the webinar for next week. It sounds like it would be of interest to me as well, and maybe I can learn something too.
Yeah, I think the announcement will come out at the end of this week.
Great.
And Catherine has put in the chat that there's one organization found that provides financial assistance for fertility preservation for Previvors, the Jewish Previvor. I'm not sure how to pronounce that. Boneh Alam.
Okay, fabulous. Thank you so much, Catherine. I really appreciate it. I'm going to copy that and I'll make a note to check it out.
Anyone else have any questions or thoughts or resources to share? Well, Marleah, we thank you so much for your excellent presentation, and the webinar will be available on the YouTube channel, and your contact information is in there if somebody wants to follow up with you directly.
Yes, that would be great. Thank you so much for your time. I know it's busy, and so it was nice to share with all of you. And please reach out if you have any questions or future thoughts. Thank you.
Thank you.